Jennifer, I think we can start now. Right?
Sure, great, thank you. Malvika, could you move the slide, please, to the agenda? Thank you so much. Good morning, good afternoon, good evening, everyone. Thank you all for joining us today. I am Dr. Jennifer Requejo. I'm currently based at Johns Hopkins University in the Global Financing Facility at the World Bank, and am a commissioner on the Lancet Commission for Adolescent Health and Wellbeing. I will be serving as the moderator of today's exciting webinar on the new MIX tool to measure adolescent and young people's mental health, and to present some of the key findings from the Journal of Adolescent Health supplement that was launched in December, which included a series of papers on measurement of adolescent mental health and on the development of this tool. We have a very packed agenda today, and I'm going to walk you through, as you can see on the screen, the agenda. We will start off with a couple overview presentations on the tool and its inclusion in the MIX survey. This will be followed by a panel on why measuring mental health matters. Then we will move into a more in-depth discussion of the new tool itself with an overview presentation of the fieldwork and other processes followed to validate and configure the tool. And then we will have a rich panel discussion on youth engagement in the tool's development and in-country implementation experiences. After all of these presentations and panels, we will have some time for question and answers coming from you all. Then we will have a wrap up of our webinar with some closing remarks from Dr. João Pedro Azevedo, the Chief Statistician and Deputy Director, of the Data and Analytics team at UNICEF headquarters. Before we get started, just a couple housekeeping messages. We will have open for you to post any questions you might have as we go along through the webinar. So please feel free to use that Q&A function at your leisure during the webinar, or you can post your questions in the chat. Lastly, just so you know, we are recording this webinar, and we hope that that is okay with you. With that, I'd like to introduce our first speaker, who is going to give you an overview of the webinar and the purpose of the tool and the importance of measuring adolescent mental health. Liliana Carvajal is currently the officer in charge for the Health and HIV portfolio at the Division of Data Analysis, Planning and Monitoring at UNICEF headquarters. She is an epidemiologist by training and a global health practitioner with over 15 years of experience. She is the global lead for the measurement of mental health among adolescents at the population level initiative that was spearheaded by UNICEF in collaboration with partners. She is currently completing her PhD at the Karolinska Institute in Sweden. Over to you, Liliana. Thank you so much.
Thank you, Jennifer. Good morning, good afternoon, good evening, colleagues. We are very excited to be here today presenting the outputs of the initiative of the measurement of mental health among adolescents and young people at the population level initiative. This is a journey that has taken about 5 years by now. You can see on the screen the core group that has really been spearheading this work from beginning to until today. We have benefited from amazing engagement and collaboration and support and advice from a group of global leads on global mental health, measurement, global health. And we have been working very closely with in-country implementations, partners in countries that you can see on the screen. I'm not going to read all the names, and you can see the enormous collaboration that this effort has had with institutions in the North and in the South. And we have also very grateful for the funding support that we have received from Bill and Melinda Gates Foundation, Rodman Family Foundation, UNICEF, and others. So it has really taken a village, as it should, because this is a really, important piece of work that we believe is going to have a very positive impact in young people across the world. Our journey started in 2018 when we developed the protocols for cultural adaptation and clinical validation to be implemented across countries. We conducted the work in 6 countries with these protocols, in which we brought tools, scales, and items to measure various aspects of mental health among young populations. We started in Belize in 2019 with our field work. This work was conducted with the support of the Ministry of Health, UNICEF office in country, and various partners. And we continue our journey across countries like Kenya, South Africa, Nepal, where we work very closely with implementation partners, researchers in collaboration with UNICEF country offices, ministries of health, education, youth. And finally, last year, we conducted field tests as part of the mixed surveys in Zimbabwe, where we did the last round of cultural adaptation. And at the moment, we're working closely with the Peru country office, which is, again, implementing the entire protocol and will be the first country who's going to be moving from cultural adaptation, validation, and now into collecting data using the new tool. So we're very excited about this journey. In this development process, we have gathered samples from about 3,000 adolescents. And this has been the basis for the development of the tool that we are presenting today. The MMAPP initiative aims at closing the data gap on adolescent and young people's mental health. And we know it is not an easy task. So therefore, we have structured our work to have 4 main outputs. The first one is the one that we are showcasing today, is a culturally adaptable and clinically validated data collection tool, which will be integrated into the multiple indicator cluster surveys starting this year. So it will be the first mixed module on mental health and mental health among adolescents and young people. And you will hear from my colleague Eva in a few minutes about the process for rolling it out. We have also developed a set of global indicators on mental health of young adolescent and young people, which is aimed to support the reporting and standardization of mental health indicators, and will allow for accountability and comparison across countries and settings. We have also worked on guidelines for cultural adaptation and data interpretation, as well as on knowledge products. It is important to note and to remember that all these tools are freely available in the UNICEF website under a Creative Commons agreement. So they are free of charge, free of copyrights, free of everything. They are public goods that we have developed and are available to use. Examples of these knowledge products and guidelines are here. For example, we are still finalizing some of these, but basically we're providing also guidance on translation, adaptation, and piloting. As you may imagine, when we talk about mental health, people across different cultures and settings express and talk about feelings and emotions in different ways. That's why it is important to have the cultural adaptation process. Professor Brandon Kohrt will take us through and give us a deep dive on this process along with our partners in country, but we're providing a guidance that has been created based on these experiences across these countries. We're also having guidance on administration and referrals in terms of how to train enumerators to conduct the data collection, guidance on interpretation of results depending on the needs or the applicability of the desired application of the results or the tools, recommendation for policymakers, and as Jennifer mentioned, we're launching today the journal supplement on measurement of adolescents' mental health at the population level, in which we have documented very carefully through a series of peer-reviewed publications the development of this work, as well as work from other experts in the field. I'll tell you a little bit more about this in a few minutes. So going back to the mixed module that we are presenting today, so the key domains of the mixed module on mental health among adolescents and young people include symptoms of depression and anxiety, functional limitations, suicidality, care seeking, and connectedness. Each of these modules has a series of questions that has been carefully developed, tested, and validated in the countries that I mentioned before. We have also conducted, particularly on the first module on symptoms of depression and anxiety, a series of psychometric analysis to really understand the degree to which these modules are valid and are relevant in the fields where they have been, developed. Again, just to remember, all these modules in particular and all the tools are really available in the UNICEF website under Creative Commons agreement. A deep dive on the module, and the idea is not to read all the text because it's very small, is that the mixed module has a unique configuration in terms of how it is to be administered. So, for example, the section 1, which is about symptoms of depression and anxiety, consists of a series of questions that starts first with 4 questions on depression, symptoms of depression, and then 6 questions on symptoms of anxiety. Depending on the answers that we get there, that the respondents give, then the algorithm will guide the interviewer to decide whether or not additional questions will need to be answered. So this unique configuration allows for efficiency in the implementation of the module, and also for very good psychometrics results that Professor Kohrt will tell us about. The next 2 modules, which are complementary and very important in terms of mental health of our adolescents, are about the functional limitations. The first one, basically the extent to which these feelings and emotions are getting on the way of adolescents living, fulfilling lives or normal lives in the school, in the community, or with their peers. We have a module on mental health care and connectedness, which is about the extent to which they are talking to others about their feelings and their emotions and the way, and if they feel understood by their parents or caregivers. And finally, we have a module on suicidal thoughts and behavior, which is a very important module, which has very, specific instructions as to how to implement it, and has tied to it, it has a referral protocol, referral instructions to be, implemented and customized by countries to make sure participants are safe and to identify needs for immediate support. Some key features of this module that are important to discuss here are the age groups. So this module we'll start to implement this module among adolescents 15 to 19 and young people 20 to 24. We conducted validation work with younger populations, but we have identified through the results that we need to continue to doing a little bit more work on the younger population, younger than 15. But the module is ready for start at age 15. It will be self-report in the sense that the questions are going to be asked directly to the adolescent and to the young people, and not asking proxy respondents, not asking parents or caregivers about, the adolescent, but they're going to be interviewed directly. And the module, given the unique configuration that I was just mentioning, can be as short as 17 questions or as long as 35 questions, right? It will depend on the initial responses that we get in the first 10 questions that will determine if additional questions will need to be asked. And one important point is that given what is expected in terms of prevalences of symptoms, a smaller fraction of the population interview will need to go through the full list of questions in terms of symptoms. This will be determined by the skip patterns that are going to be included in the administration of the module. Therefore, the administration time can be as short as 10 minutes or can be up to 20 minutes, depending on if the person goes through the whole questionnaire. Also, something very important that we will cover today is that all the content will need to be customized through cultural adaptation, which will be very important to ensure reliability and quality of the data that will be collected. So, in a nutshell, the steps from adaptation to dissemination of this module, and this goes, for example, when the module is included in the mixed survey. In particular, as we are starting with this approach, we'll start with cultural adaptation. And as I said, the steps will be presented in a few minutes. The country teams will need to identify referral pathways for the provision of mental health services. And this is done as part of the survey design and preparation of the survey. This is done with stakeholders in countries that usually will include Ministry of Health, Ministry of Education, other ministries, and divisions in the country that are supporting and providing mental health services. And this will be important for establishing a referral protocol, basically having a plan that can be available in the case of any respondents to the survey need extra support or need to see be sent for referral. Once that process is in place, and it's a process for which, as I mentioned before, we are preparing the guidance and we will making them available in the website, the data collection can start regularly because the trainers will be trained and, they are going to be part of, the module will be part of the whole data collection effort. And then data analysis will be conducted. And for data analysis, we also have various options in terms of how the mental health data can be analyzed, right? They can be, we're preparing automated analysis for like understanding the results and the, that we're getting from this data. But we also are producing templates for this interpretation and adaptation in terms of if the data will be used, the results will be used for population or for additional research or additional purposes. And as last step will be disseminating the results. On this step, an important part of the MMAPP approach is to involve young people and adolescents in understanding the results, in being, using them for advocacy, and to really have them as a tool for advocacy for the well-being of their own and their peers. And lastly, as I mentioned, one of the knowledge products that we have developed as an output of the MMAPP initiative is the journal supplement. We were very happy to have this issue coming out last January. It was a rollout series in which articles started to be published for the past few months. This journal is freely available, it's online. It includes a series of 17 papers that document the scientific process behind the development of this tool, as well as country cases for cultural adaptation and validation. We have some of our principal investigators from these developments today, and they are going to be discussing their experience with us in the next panel. And in this journal, we have also included very interesting articles produced by young people working in U-Report and working in other, aspects of mental health measurement, as well as other efforts like the NAM surveys and important tools like the CIDT. I believe the links are provided in the chat. Thank you.
Thank you so much, Liliana, for that excellent presentation and overview of the materials, including the journal supplement. Very exciting. So now I would like to turn us over to Eva Quintana, who is going to describe the rollout of the MIX-7 and the inclusion of this new tool in the upcoming surveys. Eva Quintana is a survey methodologist with UNICEF's MIX program. Her expertise covers survey design and implementation, development and testing of survey questionnaires, data collection methods, and research ethics. Eva came to UNICEF in 2015 from Columbia University, where she was involved in evaluation of an integrated approach to rural development across 10 research sites in sub-Saharan Africa. Thank you so much, Eva. Over to you.
Thank you, Jennifer, and hello, everyone. I'd like to start with a brief introduction to the MIX program for those of you who are not familiar with it. MIX is the global household survey program that was launched by UNICEF in the mid-90s, in 1995 to be exact. And over nearly 30 years, UNICEF has been partnering with governments to carry out more than 350 MIX surveys across nearly 120 countries. And it's over the years, MIX has become an indispensable tool to support effective policy and programming for children and young people. Over this time, MIX has evolved and grown, and basically to respond to the changing data needs. And this has resulted in the expansion from the 28 core initial indicators in the MIX initial MIX and to the current 177. MIX has also been leading on the development of the measurement of some child-related outcomes and indicators that have been now adopted in global monitoring frameworks. And currently, MIX covers the largest number of SDG indicators of any household survey program. And over time, MIX has also adopted a number of technological and methodological innovations. And here I'm highlighting 3 of them. One is MixGIS, which is basically we're mainstream geocoding to make available geospatial data for as many mixed surveys as possible for research and programming purposes. We've launched Mix Plus, which is an initiative to conduct longitudinal panel phone surveys, in many cases based on a representative subsample of mix. And also we've launched MixLink, which is an initiative to integrate mixed data with other data sources like administrative data from health facility records or education monitoring and information systems. Next. So here, just like maybe to emphasize the power, the analytical power of measuring mental health in a multi-topic survey like Mix. As you know, like Mix, or some of you know, Mix collect a wide range of indicators on the living conditions and the well-being of adolescents and young people. And so this can range from educational attainment, schooling status, or learning outcomes, to the way children and young people use their time, how they engage in child labor and paid care, domestic work, what is their access to basic services, including healthcare services, what are the characteristics of their households, and wealth and multidimensional poverty, etc. So really collects data on a range of indicators that can be considered potentially risk and protective factors for mental health outcomes. And so with the inclusion of a mental health module in Mix now starting this year, countries will have a better understanding of the relationship between risk and protective factors at individual and household level and outcomes in mental health. Next, please. So now maybe sort of an overview of how we're planning to roll out and scale up the mental health data collection at the population level through Mix. Some of you may know that this year marks the launch or the start of the 7th round of the multiple indicator cluster surveys. And we're starting this round with a series of regional workshops across the globe, in which we are going to be interacting and with countries who are interested in Mix or already planning to implement Mix. And it will be an opportunity to expose them to the new content, the new modules, including the mental health module. So here's some features of Mix, just for to give you a sense of the scale also of this 7th round of Mix. We expect about between 60, maybe 75 countries to participate in the round. This is based on our the participation of countries in the last few rounds. Like our Mix 6 round had the highest participation with 76 surveys. And we expect at least half of these countries to adopt the mental health module, if not more. One thing that I believe is important to keep in mind is that Mix is implemented and owned by countries. And so countries join the program, implement Mix with technical support and technical guidance from UNICEF, and they are able to implement the surveys with funding support from a number of donors, but also contribution from governments themselves. So as we engage in the process of launching and preparing for Mix 7, there is an opportunity at every country level to engage in discussions with the stakeholders and to advocate for the inclusion of the module, the mental health module in Mix. Thank you.
Thank you so much, Eva, for that great presentation. It's really exciting to see that this tool will be included in the Mix program. It's just a wonderful opportunity for countries to be able to collect information to get a sense of the burden of adolescent mental health so that they can begin planning their programs so that they can address it, and also allows countries to have some comparable data so that they can monitor trends over time, as well as compare how well they're doing to other countries. So thank you very much for that. And I think it's a perfect segue to our very first panel that will explore in more detail on why measuring mental health is relevant. And for this, we will have a moderator, and that will be Jill Whitney-Oz. Jill is currently, she's a mental health epidemiologist. She has been a consultant for UNICEF on adolescent mental health for several years, and she is currently completing her PhD at the Karolinska Institute in Sweden, where she researches expressions of suffering as well as adolescent engagement. I'd also like to introduce to you the panelists that will be part of this discussion. So we will have Dr. Joanna Lay. She is currently a health specialist at UNICEF headquarters, where she serves as the health section technical focal point for adolescent, school, and mental health. Her background is in planning, delivery, and evaluation of health and counseling services for children and adolescents through healthcare facilities, school, community, and digital platforms. We will also have Dr. Regina Guthold. She is currently a scientist working on adolescent health monitoring and evaluation in the Department for Maternal, Newborn, Child, and Adolescent Health at the World Health Organization. She holds a PhD in health sciences and has over 15 years of experience in surveillance, monitoring, and evaluation of adolescent and adult health. We also have with us Ms. Amnia El Omrani. She is the first official youth envoy for the COP27 president, and she is a medical doctor from Egypt. She is a commissioner at the Lancet Chatham House Commission on Post-COVID Population Health, a youth sounding board member of the EU, and a member of the Global Youth Coalition for Road Safety, and the first cohort of the UNICEF AZ Youth Leaders Program. So with that, I'd like to hand it over to you, Jill, to moderate this panel. Thank you so much. Over to you.
Thanks very much, Jennifer. Joanna, let's begin with you. Joanna, you're the health section technical focal point for adolescent, school, and mental health at UNICEF. How do you see population level measurement efforts on adolescent mental health benefiting UNICEF's global programs, particularly those with mental health components, which may be implemented across multiple countries?
Great. Thank you so much, Jill. Yeah, I mean, definitely to address adolescent mental health programmatically, it really does start with data, not only on prevalence of mental health conditions and symptomology, but also around the factors that are helping or harming mental well-being of young people across different regions, socioeconomic and cultural context. And so being able to systematically measure mental health outcomes, risk, protective factors at this population level for this age group, it's central to helping us guide us in coherently designing policies, services, programs that are relevant and responsive to the needs of adolescents in a given setting. And we know that this is particularly important because adolescents as a population group, they have such wide-ranging experiences and needs when it comes to mental health. And I think in particular, routine data that MMAPP within mix or other population level surveys could provide us with over time is really important for monitoring mental health inequities both at a national and subnational level, to know what types of support and services are needed most by whom. It's important for us to know where and how we can make improvements in mental health implementation and prioritization of services for adolescents. It informs us where resources could be most effectively allocated, not just within the health sector, but also in education and social protection and others. And of course, we need this data to track progress on programmatic and policy action investments. So I would say that the lack of such data is actually a hindrance for adolescent mental health policy, as well as implementation of services and programs. And I'm really glad to see the global launch of MMAPP and really looking forward to its integration with programmatic efforts for adolescent mental health.
Thank you. Thank you. Now let's go to Regina. Regina, you lead the global action for measurement of adolescent health group, GAMA, at the World Health Organization. Based on your experience leading GAMA, why is mental health measurement important to improve the health outcomes of young people?
Thank you so much for this question, Jill. Maybe to give a little bit of background information on what GAMA actually is. So GAMA is an international expert group that advises not only WHO, but also 7 other UN agencies, including UNICEF, including UNAIDS, UNESCO, and others, on how to improve and harmonize adolescent health measurement broadly. Not only mental health, but broader than that, mental and physical health. So to focus global and national adolescent health measurement on the most important issues, the GAMA advisory group has gone through a very systematic process to select 52 priority indicators to be used for adolescent health measurement. And these indicators, it's currently a draft list. They're being further assessed in a 12-country feasibility study, but that list does include 6 of the MMAPP indicators that Liliana referred to in her presentation, namely indicators around having somebody to talk to, connection with parents, suicide attempts and thoughts, and symptoms of depression and anxiety, and also seeking help for these symptoms. So that's the indicators that are also promoted by GAMA. But the list also includes other indicators that are related to mental health, such as poverty or alcohol use, drug use, physical activity, and others. But back to your question, why do we need to measure adolescent mental health and related aspects? And Joanna has alluded to this already in her response to her question. Adolescence is a crucial period with developmental changes, and they're rapid, these changes. So it's not easy to deal with all of these changes. Unfortunately, many mental health issues manifest during adolescence, and then they lead to negative health outcomes during adolescence, but also later in life, during adulthood. They can go along the whole life course, in fact. So adolescence is a crucial time period to intervene and to act before these mental illnesses manifest, and to strengthen the resources of adolescents. And to do this, to intervene and to act appropriately, we need good data to know what exactly to do. Only good data give us a good picture of the overall health and well-being status of the adolescent population and can guide our actions. Thank you.
Can I follow up on that, Regina? I understand GAMA promotes as much as possible the use of priority indicators, ones that are used already or tested or validated. Can you share more about why that's important for mental health data?
Yes, so I guess there are 2 aspects. One, to promote the use of indicators that are already out there, and that is really to build on what's being done already, to not start from scratch and invent new things, but to really build on what's there, what people know, what people have done before. That's number 1. And number 2, why use indicators that have been tested? Well, if indicators have not been tested, we really don't know if we are measuring what we mean to measure. And that's in terms of measuring precisely what we want to measure, but also being able to do repeat measurements. So as you said, as much as possible, we want to promote indicators that are already out there being used and having been tested before.
Thank you. Now to Omnia. Omnia, as a youth advocate with a background in public health, how do you think data on adolescent and young people's mental health can support the efforts of youth advocates worldwide like yourself?
Yes, thank you so much, and congratulations on the launch of the MMAPP. And I think it's very critical because young people, particularly children and adolescents, right now are shouldering the impacts of the global polycrises that we are seeing, whether it's COVID-19, climate change, especially on mental health, where we see the impacts of climate change on mental health versus physical health is 40-1. But at the same time, when we look at the gaps and the needs of young people, especially when it comes to data, there are three main things. The first, that there are still persistent inequities when it comes to the understanding and the access to the information that adolescents and young people need to support their mental health. And this disproportionately exacerbates the impacts of such events like COVID-19 and the climate change on the mental health of young people. The second thing is that it's very challenging for young advocates to find the right mental health resources and support that meets their needs, that is responsive to adolescents, that is culturally relevant, that it is not, that is co-created in a way with them so that it is relevant, effective, and appropriate to really support them fully. And the final thing, and which is very important, is that youth leadership, the leadership of young advocates and their voices, is still often undervalued in the global landscape. And these are the needs and the barriers and the challenges that we need the data to translate this to the research community, to the policymakers, to really create appropriate and effective decision support tools to translate the data into policy. And one thing I also wanted to share is that specifically when we look at the MMAPP and how powerful it can be to really collect data with a bottom-up approach from adolescents and youth. And this is very important, especially in issues such as climate change. And I'm very happy to now be working together on a very exciting initiative that will be launched on April 18th. And I think it can be very relevant to the work of MMAPP together with Imperial College and Wellcome Trust on an initiative that is going to inform the research agenda around climate change and mental health. And this is also my final point, which is the importance of breaking down the silos between the different communities, especially when we're looking at the data collection and its integration and its monitoring and its translation into policy.
Thank you. Thanks so much for your thoughtful responses. And now, very briefly, to each of you, a final question. Imagine you have 1 minute to give an elevator pitch to a policymaker or leader in your national or global advocacy about investing in data on adolescent and young people's mental health generated by the MIX module. What's one thing that you want them to walk away with? And let's go right back to you, Omnia.
Yes, if I have 1 minute, I would say that the needs and the information and the perspectives that are led by children, adolescents, or youth are central to any initiative or intervention or to really our health and the health of the planet. So we need to invest in understanding and listening to the needs of the adolescents and the children to really create the most effective, the most equitable services, support systems for this generation and the generations to come.
Thank you. And next, Regina.
Thank you, Jill. So I would really like policymakers to understand that adolescent mental health is crucial for overall population health and happiness and productivity, but that unfortunately currently mental health conditions are the #1 cause of ill health among adolescents. And we must work on improving this, on preventing mental ill health and on strengthening adolescents' resources. But in order to do this, we really need good data so that we can measure progress and that we know we're doing the right things.
Thank you. And finally, Joanna.
Yeah, I would probably just say that data on adolescent mental health right now is so extremely sparse, especially in low and middle income countries where the data coverage we have represents, only about 2% of the adolescents living in these settings. And this is striking because we have 90% of the world's 1.2 billion young people living in low and middle income countries. So we need this so we know how to implement and monitor effective and appropriate policies and programs and resources for this population group.
Thank you. My sincere thanks to each of you, the panelists. And now I'll hand it back over to you, Jennifer.
Thank you so much for that excellent panel and great discussion. We are now going to move into the next part of our program, but I just wanted to reiterate some of the key points from that discussion around the importance of this tool for helping to improve data availability that will enable countries to monitor and assess the burden of adolescent mental health, which can then translate into effective programs and monitoring over time so that they can track their progress on how well those programs are reaching the needs of adolescents. And then also really appreciated both the comments that put the measurement of adolescent mental health within the broader landscape of measurement in general for adolescent health, as well as thinking about that crucial time point in adolescence where whatever the services that are provided to improve adolescent mental health can have immediate as well as long-term impacts on their life opportunities. And then also really appreciate the whole emphasis on the co-creation of the data with adolescents themselves so that the data is actually reflective of their real realities and is more likely to result in programs that are effective and responsive to their needs. So with that, I'm going to now turn us over to Dr. Brandon Kohrt, who's going to give us an overview of the tool validation fieldwork and the learnings from developing this particular tool. Brandon is a professor of psychiatry, global health, and anthropology, and the director of the Center for Global Mental Health Equity at George Washington University. His research addresses strategies to improve the delivery of mental health care, the measurement of mental health, and reduction of stigma in humanitarian and low-resource settings around the world. He has served as a senior technical advisor to UNICEF's Measuring Mental Health of Adolescent and Young People at the Population Level Initiative for the past 5 years. So with that, a warm welcome to you, Brandon, and over to you for your presentation. Thank you so much.
Thank you so much, Jennifer, for this opportunity. And thanks to everyone for participating today to hear more about the launch of the MAPP tool. Next slide, please. So as Liliana described earlier, what was very important was a rigorous and long process of developing this tool. We know that there are a range of different tools available globally for assessment of mental health needs amongst adolescents and children. However, most of these tools have not been validated in low and middle income countries where we know the majority of the world's adolescents live. In addition, when tools are not appropriately adapted and validated, they can lead to misleading or misrepresentation of the burden, either substantial overestimation or underestimation, which makes it very difficult for planners, for youth advocates, for public health officials to adequately deliver public health programs. What we did was a mixed cultural adaptation and clinical validation process. This was done primarily in 4 countries, Nepal, Kenya, South Africa, and Belize, with additional cultural adaptation and field testing in Zimbabwe, and we have ongoing validation work in Peru as well. Next slide, please. This is the process we used, and I just want to point out that there's a simplified version of this process that we'll talk about in a moment and that Liliana provided earlier, so that now when each country is taking up the mental health adolescent module in the mix, they're able to do this in a much more rapid fashion. For our rigorous approach, we had a 5-step cross-cultural adaptation procedure. This is a standardized procedure that has been developed by colleagues of the World Health Organizations and used widely with children and adolescents for rigorous tool development. I want to point out 2 of the key pieces. One is the importance of review by mental health experts in the country where the tool is going to be used, because they are familiar with the common signs and symptoms and how to describe them in easy to understand language. However, this alone is not enough. The other key element is engagement with youth themselves, with adolescents, to learn from them how they describe the experiences of depression and anxiety. In the rigorous procedure used here, we used a series of focus group discussions and a process called cognitive interviewing, and we've developed simplified guidelines to engage with youth leaders when going forward in new countries. In addition, the other key component here was to check and see if the tool and the items included were consistent with the experience of clinical level depression and anxiety. And to do this, we used a standardized tool known as the KSADS that was administered by psychologists, licensed clinical social workers, or psychiatrists in the different countries to have a standardized clinical diagnosis to compare against the items on the tool. So in each of the 4 countries that I've mentioned, we've done a full analysis and have one of the largest samples to date from low middle income countries for this procedure, with nearly 2,000 adolescents included. Next slide, please. So as presented earlier, this is what the tool currently looks like, and it's available in a number of formats for administration in the mix, but also individuals can choose to use it in other surveys, public health programs, research studies. As mentioned, it has a 2-part component. The first is a screening procedure of 10 items, and then sub-modules for anxiety and depression. We went through a rigorous process to find those screening items that were consistent with DSM and ICD diagnostic criteria, and in addition had the highest sensitivity to be able to capture 90 to 98% of those adolescents with these conditions in the different regions around the world. After doing this, individuals then complete a series of submodules to be able to determine actually if they are likely to meet that criteria that suggests they may have depression or anxiety and need additional supports and services, and to provide accurate population level estimates of the burden of these conditions. Next slide, please. Here are some simple overview statistics about how the MAPP tool performs. The important part is that sensitivity of the screening component is high. In addition, the submodules have higher levels of specificity to reduce the number of false positives. However, we will get to in a moment more detailed ways to be able to analyze the data that go beyond traditional sensitivity and specificity to be able to estimate in an easy to use way the closest accurate prevalence of these conditions in countries where mix is being conducted. Next slide, please. A very important part for policymakers, for clinicians, for public health officials is also to be able to correlate these with the DSM and ICD criteria for these conditions. So we have functionality in the tool so that individuals can also determine if someone would meet criteria for either DSM-5 or ICD criteria for depression or generalized anxiety disorder. In addition, for those individuals that may use some other types of tools, we have the ability to calculate equivalency scores for tools such as the PHQ-9, PHQ-A, and GAD-7. Next slide, please. So, how can individuals use this tool going forward? The important part is that this has to be something that is feasible and doesn't require a large research team to be able to be implemented. So we've broken it down to 5 steps that can be replicated in preparation for a mixed survey or for other uses around the world. The first is the translation by bilingual experts, followed by that expert review from local mental health clinicians, and most importantly is a series of guidelines around youth engagement and having youth advisors take part in the process to really identify what language is comprehensible, acceptable, and relevant for them. Then a triangulation process to modify the tool, a back translation, and then you're ready to go and use it in your local setting. Next slide, please. One of the advances we tried to make was to move beyond fixed language so that the idea that the same exact word has to be used in every setting. And so, based on the multi-country piloting, we've identified a host of different terms that can be used to be able to talk about common symptoms in a way that is easy for adolescents to understand. So the tool not only has standardized language, but a range of suggested and acceptable alternative wording that can be considered during the translation process. This is important because many tools do not exist currently that have these types of suggested alternative wording. Next slide, please. And as I mentioned, rather than taking all symptoms associated with depression and anxiety and treating them equally, there are algorithms that are easy to use and programmed into support tools with the administration of the MAPP to be able to identify that some types of symptom clusters are much more predictive of the likelihood of depression or anxiety, where other types of symptom clusters may be less associated, especially thinking in a global context. So rather than a one-size-fits-all approach to scoring, we actually look at the different constellations of symptoms to help to be able to make as accurate as possible a population predicted level of depression and anxiety. Next slide, please. So what's the ultimate contribution of the MAPP tool? First and foremost, this is free for use, translation, adaptation, and dissemination. This will be calculated under a Creative Commons licensure, which allows for translation by anyone using it in different settings as long as they cite the original tool. In addition, they can disseminate and use that as needed in their settings. This does not limit then everyone having to come back to the developer of the tool or pay a fee to be able to use this. The goal really is for wide circulation. Second, it has this embedded guidance around cultural adaptation. Rather than each person having to go through their own separate approach on cultural adaptation, having minimum standards will help to assure that the tool is acceptable, comprehensible, and relevant in each setting. Next is a range of guidance around understanding what the outcomes of the tool mean. As Omnia mentioned just a moment ago, the importance around decision-making aids that come out of the numbers here. So how can this information be used best by youth advocates, policymakers, and others in a way that is going to be accurate and reliable in their settings? And then finally is the importance around this should always be developed for and with adolescents. And so our process to develop the MAPP tool really had high levels of adolescent engagement. And our goal as this gets disseminated is that there's always adolescent engagement with each new setting where the MAPP tool is used. And with that, I turn it back over to Jennifer.
Thank you so much, Brandon. That was an excellent overview of the steps involved in developing the tool, the very rigorous steps involved in its development and validation. Also, the really helpful overview of how people can use the tool. And as you stressed, that you've embedded within it the cultural adaptation guidelines, which is fantastic. And then also just that the whole consideration about feasibility when the tool was developed. And also just really appreciate the additional added value and stress on the engagement with adolescents as the tool is adapted and used. So that is actually a perfect segue to our the panel discussion, which Brandon is going to be leading, which is talking about the implementation process. So learning from the experiences of when the tool was being developed on how the collaboration went with young people, and then also some of the other experiences on implementing the tool in several countries. So I'm going to hand it back to Brandon, but first I'd like to introduce the panelists. We have three. The first is Dr. Nagendra Lutel. He's a global mental health researcher from Nepal. He holds a PhD on the integration of mental health services into the primary and community healthcare system in Nepal from the University of Amsterdam. Currently, he is the research advisor at Transcultural Psychosocial Organization in Nepal, which is a national level non-governmental organization. Then we have Manasi Kumar, Dr. Manasi Kumar, who is working as a senior implementation scientist at the Brain and Mind Institute at the Aga Khan University. As an affiliate senior lecturer at the Department of Psychiatry, University of Nairobi, she is involved in National Institutes of Health-funded research on peripartum adolescents living with depression. And she has wide experience in mentoring lay, non-specialist, and specialist health workers through WHO's, some of WHO's programs. And with that is Dr. Manasi Kumar. And then lastly, but not least, of course, is Dr. Marguerite Marlowe, who is a senior researcher in the Department of Global Health at Stellenbosch University, South Africa. And she is also the technical research lead for the university's Institute for Life Course Health Research. Her research focuses on child and adolescent development and parenting in low resource settings. So with that, Brandon, I'd like to hand back to you so that you can lead us through this panel discussion. Thank you so much.
Thanks again, Jennifer. I actually want to start with Marguerite and the South Africa team. I know that part of your work was to engage an adolescent advisory board, and this is something that's important for a lot of the research that you do at Stellenbosch and other colleagues do in South Africa. Can you give a little bit of information to others on the call today about the process of engaging with adolescent advisory boards and what recommendations you would have for them as they take this on in terms of adapting the MAPP tool? Thank you.
Sure, thanks, Brandon. So I just like to kind of preface this by, the need for working with adolescents through this process. South Africa is a multilingual country, national language or official languages, and there has been really slow progress in terms of achieving greater access to mental health services on the basis of language, and particularly for adolescents. So in this context, that translation process was incredibly important, not just in terms of the language that's used, but also how those translations and adaptations are done and who is involved in that process. So we found that working actively with adolescents in various kind of capacities was incredibly important, not only for the translation, but also the adaptation to kind of tap into local conceptualizations and understanding of mental health and what that looks like in this particular setting. And so having gone through this very rigorous process and, various steps in terms of adaptation and translation, we really found that those groups with your adolescents, whether that's an advisory group or with local adolescents, that really worked very well to tap into the important changes that are needed in a similar way that we found with other more rigorous or as rigorous processes such as the cognitive interviewing and that. So if there's anything to focus your resources and your time on, it would be to make time for those groups and actually workshopping the items with adolescents, because it's definitely proven to be one of the most valuable things that we did within this context. Thanks.
Thank you, Marguerite. And that's a great transition to Nagendra. So Nagendra, as an organization, you and Transcultural Psychosocial Organization have been doing these transcultural translation and adaptation processes with young people for many years, actually. Can you give some examples of what you've learned from qualitative work that has led to improving tools such as these?
Well, so thank you, Brandon, for this important question. Yes, we have done a lot of work with young people, particularly translation and adaptation of standard tools. We have learned a lot of experience actually from this exercise. So first, Nepal is quite diverse in terms of caste, ethnicity, language, and culture, and also geographical diversity. So what we learn is that the tools adapted and used in one group is not like appropriate or understandable for another group. That's why a proper cultural adaptation is needed when you use the tool in another culture or another geographical area. That's the important lesson we learned. Similarly, we often get a comments from young people, not only young people, also with adults, is that most of the tools are in statement. So they often recommend us to make the statement into question form, so it is easier for them to understand. So that's another important lesson that we learned. And another important things we learned from the qualitative interview about the bodily complaints, that is physical complaints. Most of the standard tools, they lack those symptoms. They are really important for mental health. So we recommend to include this in the tools. Similarly, we also get a statement from Adolescent is that that one item should include one idea only. Currently, if you see the commonly used tools, then you will find one item have multiple ideas. So it's really hard for adolescents to go with which idea, first one or second one, or maybe sometimes third or fourth one. That's why they are strongly recommended to have one idea in one question. And another interesting thing is that, like in many tools or many items, we need examples to make this clear, because sometimes the tool itself is not clear. So example also changes over time. So we need to adopt the tools to adjust young people's experience, their current experience that could be different from 10 years ago. We often stuck with the language and examples that are being used in the tools, which are actually fixed in 10 or 20 years before. That's why what we learned is we need to revise them with time. I can give you a particular example when asking adolescents about the pleasurable activity they have. Then when we were doing this 10 years before, visiting to maternal uncle's house was the most pleasurable activity. Everywhere we used to get that example, but this is now changed. If you ask the same question to adolescents, then playing with mobile and visiting, these are the most pleasurable activities. So we need to adjust this in the new tools. And finally, we found the cognitive interviews to be like quite helpful, because in the FGD we mostly ask them if the language used in the tools is acceptable, comprehensive, culturally appropriate, which is good. But in the cognitive interview, we learned whether a particular adolescent, how they link with those problems in their day-to-day life. And it's really helpful to understand how the adolescent, they understood the item and whether it is applicable with them or not. I do have many other examples, but I'm not sure if you allow me to tell more. Thank you.
Thank you very much, Nagendra. I think we'll move on to Manasi. Those are fantastic examples. Manasi, I want to take it to your experience in Kenya. And as you've pointed out, many indicators are commonly being collected for adolescent health. And increasing, in many national surveys are interested in mental health, also indicators for adolescent mental health and health management information systems. How do you think that the adolescent and development process that you used in Kenya and has been described here is contributing to more adolescent-friendly approaches to capturing accurately these indicators in national surveys, health systems, and so on?
Oh, thank you so much, Brandon and colleagues, for this webinar. I think what we tried to do in Kenya was to leverage the existing health system actors. So we had community health workers, primary care clinicians, and extended pipeline of specialists who got involved in the adaptation process. So right from the ground, and then we had an extensive advisory group that comprised of a mixed group of individuals with some young people, but on reflection that also we would strengthen going forward. So what it did was to make people aware about how multidimensional mental health issues are with regards to adolescents. The time we were working, we were also looking at 10 to 14 years. So the focus was much more on protection, on making sure that there is safeguarding. And I think those kinds of questions triggered stances where more responsiveness needed to be had. And everybody thought it was a great opportunity to understand what young people's strain, stress, how critical parenting and families and communities was. We did this exercise, like perhaps with our colleagues in South Africa and Nepal during the pandemic. So we learned a lot about what it means to be mental health friendly and how world would improve in many ways. And I'm excited that MIX already has a range of indicators that will contribute to the discussion on adolescent responsive processes and indicators as such. So thanks, Brandon.
Great, thank you very, very much. We have time for just one more question, and I want to raise something back to Marguerite. One of the experiences in doing this, both in Kenya, was to look both at English and Swahili, and in South Africa to look at isiXhosa. And I'm interested, Marguerite, from your experience as English becomes a common language amongst more and more adolescents around the world. Why do you think it's important to also make sure that these tools are developed in other appropriate languages beyond English.
Mm-hmm. Thanks, Brandon. Yeah, so I think given South Africa's political history and, you know, of apartheid and colonialism, it has meant that most of the languages have been marginalized, and that English and Afrikaans are, you know, that services have always been available in the way that people kind of think about and talk about mental health. So having tools in the local languages is incredibly important. So it was quite interesting that, you know, in the discussions with adolescents, what we saw is that the translations into isiXhosa that were done by the mental health experts, the adolescents often felt that that was the wording was too deep or too kind of formal. And so a lot of time was spent actually adjusting the wording. And in a lot of cases, there would be kind of English alternatives provided alongside that. But I think combining both is important, especially thinking about different contexts across peri-urban, urban and rural sites, and that this will look different in different parts of the country. So having this approach, I think, is really valuable, you know, working with just adolescents from different backgrounds and supporting that.
Thank you. Thank you all very much, Nagendra, Marguerite, and Manasi, for the incredible work that you've done. And just to highlight, for those of you who go forward with this process, that our experiences have been working with youth advisory boards, adolescent advisory boards, makes a tremendous difference to ultimately produce tools that are meaningful and understandable to adolescents and will produce the most accurate and reliable data for strong public health and other programming. Back to you, Jennifer.
Thank you so much, Brandon, and to the three panelists. That was excellent, and I really appreciate the sharing of the experiences in Kenya, Nepal, and South Africa on the importance of adapting the tool into local languages, as well as using the languages or words that adolescents themselves use to describe their experiences. We now have some time for questions and answers, and thanks to all of the participants who've put in some very tough and interesting and important questions in the chat. So I'm going to start there. There's a great question for that I think I'm going to pose to you, Brandon. So there's one that is coming from, and I apologize to all of the to people if I really don't pronounce your name correctly. So from Sirirath Chunasart, she was asking this point about how it seems like the MMAPP tool has some indicators that are very similar to the global school-based survey. And so she was just asking, what is your advice on reconciling the mental health indicators in both surveys, especially if countries are interested in doing them both? And then similarly, just maybe if you can describe more broadly how you think this new tool is different from existing tools and surveys that measure mental health outcomes in adolescents. Thank you. Over to you.
Thank you so much for that important question. So there are a couple of points here. One is that at the moment, what is great about where the field is going is that we are working more and more towards common indicators. The challenge becomes, how do we get there? And if different tools with kind of widely divergent approaches, some validated, some not validated, some adapted, some not validated, some not adapted, then understanding what those indicators mean could be quite complex. So our hope is that there can be more and more harmonization around the operationalizing of indicators and the types of questions that are used to generate those indicators. Absolutely crucial to this is transparency, which is what we hope to do with the MAP tool, to be very clear about how those indicators are generated so that others could replicate that in different settings and compare with how indicators might be generated from different types of tools, which is also why it's so important to have this comparable to generation of prevalence rates based on something like the DSM or the ICD, or tools such as the PHQ or the GAD-7. So really trying to crosstalk these different strategies so that ultimately we hope that we're talking about the same thing with a rigorous standardized approach going forward. Thanks.
Great, thank you, Brandon, super helpful. So there's another question that I think is really appropriate for Eva, if you wouldn't mind answering this question from Myron Belfer. So he is asking about how can you identify focal points for supporting the assessments that you're proposing? So I think this is related to the mixed rollout. So he's given some examples about at WHO with data gathering associated with the Child and Adolescent Mental Health Atlas. Many who were identified denied the ability or competency to support the data gathering. Okay, so it's sort of around who will be your implementers in the field or at the national level. So that I think is related to your mixed rollout. And then also just this whole issue that I know you're very familiar with is the burden as the mixed survey expands in content, is that puts a lot of burden on the data collectors. So over to you for that question.
Yeah, so I think on the focal points, yes. So with implementing agencies for mix are typically the national statistical offices, but mix, engages in the process other stakeholders, like being a tool, multi-topic, cross-sectoral tool. There's always focal points from different sectors, and at government level, this means from different ministries and government agencies. But also, it could be stakeholders like in, UN agencies that support the mix implementation. So there are different platforms and moments or times in the process where you can actually engage and bring the appropriate people to the table to discuss, from the beginning, we start with a data gap assessment, right? So the idea is that mix offers this wide range, very extensive tools and a very long list of indicators, but that doesn't mean that every mix needs to collect all these indicators. So basically, we'll start with a discussion about data gaps, right? And that's where you need to look at in every country, through the steering committee for the mix that will be established, and there are discussions where the decisions about what indicators to include or not are happen. And then with regards to the specific mental health module, there are some implications for implementation that have to do with developing, identifying the right agency or stakeholders that can support, providing psychosocial support during field work in case that, we need to refer participants to, who are considered to be at high risk. And so, yes, there is, there are different levels or layers of involvement for focal points. And so, yes, we start with government counterparts, right? It would be in the Ministry of Health, who would be the right, mental health, counterparts. And then we may engage also, depending on the country context, right? We may engage with also organizations that are working closely with government or with UN agencies, with UNICEF in, programming around, mental health and psychosocial support for adolescents. So yes, so there are, I think it varies across countries, but there are, sort of like this engagement and identification of relevant focal points for each of the sectors that, that mix covers. It's already sort of like embedded in our, sort of like framework for, and survey design process. I hope that answers the question. And then in terms of burden, yeah, I think I touched upon that a little bit when I said that obviously, there are many indicators in mix, but countries are not necessarily, deploying, all these, the entirety of the tools. So it really is a balancing act between, identifying key priority data gaps, also looking at funding resources, and we really encourage always in this process countries to be really as efficient as possible in terms of like collect the data that is most relevant in terms of programming and policy for the country, and without also compromising potentially the quality of the data, right? If we collect too much, it may be that we have a harder time and monitoring and controlling for data quality during fieldwork.
Great, thank you so much, and really appreciate the important relationship that Mix has with country governments and making sure that the surveys are are tailored to the country's specific needs and priorities, and also this balancing act of limiting what's collected to ensure data quality. So thank you so much for that. There are a couple of questions that I would now like to pose back to you. Liliana, I think you might be best placed to address these. So the first one is from Shane Kahn, and it's around this: how would you define a quality referral protocol? That is, are guidelines available on this, and how can surveys assess if the protocol was useful and used? So Liliana, I hope you can address that. And then just sort of adding on to it as you're answering, there's a question in the chat from Abhilasha Garoon, and she's asking, as you mentioned in your opening remarks, that the tool right now is for 15 to 19 and then the young population of 20 to 24. And she is asking the whole, like, when you expect that there could be questions ready for the younger population group of 10 to 14. So over to you, Liliana.
Thank you so much, Jennifer, and thanks to Shane and Abhilasha for these questions. The referral protocol is an important component of the MMAPP initiative of the products that we are making available. A quality referral protocol will definitely have the guidelines. So we're going to put up guidelines which we have produced based on our experience in the countries where we validated the tool. Countries in which, for each country, we develop a specific referral protocol, and this is done basically in consultation with national local stakeholders. These stakeholders usually involve ministries of health, service providers, young groups, youth networks, ministries of youth, all, in every country is different. So it is a matter of, like, when, as Eva was referring to, when the survey is implemented, have the right stakeholders around the table to be able to identify how does the provision of services look and what services can be made available and provided to survey participants. All of this will be guided by the documents and the guidelines we are issuing as part of the MMAPP initiative, but definitely will require a dedicated country customization at the moment of survey design. And in terms of the question for Abhilasha, yes, we conducted the validation, including younger population, as young as 10 to 14. But as I mentioned, we need to have more time and think about, like, what process will work better for them. The validation results that we got for that group were not bad, but were not. We identified that this is not ready to be rolled out as a global tool, as we are. We're not confident about that at the moment. However, the results were in a point that where we hope we can, get some progress soon. By when, I cannot tell you exactly a date. We are prioritizing the rollout of this to age group, 15 to 19, 20 to 24. But I would say maybe within the next couple of years, we would be ready to have the methods refined for that specific age group and be able to include it in the expansion of the age group, starting with the mixed surveys. This is something that we are already discussing with the mixed surveys, and there is openness to that idea. So we're very hopeful about that. It just requires a little bit of more refinement in the validation process. Thank you.
Thank you so much, Liliana. It's very exciting, and I know there are additional challenges with that younger age group, but it's great to see that it's on the agenda, and we'll see that tool soon. We have time for one more question, and I'd like to turn to you, Joanna. Thank you so much again for describing the programmatic and policy implications of the MMAPP tool. So just to you, I'd just like to ask if you could describe a little bit more how the data that will be collected through the use of this tool, how will it be used to inform policy and programmatic interventions that are really aimed at improving adolescent mental health outcomes? Over to you. Thank you so much. Joanna, are you, and if Joanna is not able to unmute, it would be helpful. Any one of the panelists and presenters, feel free to answer that question. Maybe Liliana or Brandon, given that would be great to hear from you. Go ahead, Liliana.
Sure. Thank you so much. And I see Manasi's hand up also. So I just briefly say that At the core of this initiative of generating this data is to inform policies and programs, is to have a conversation that is evidence-based with policymakers, with donors also to help us invest in this specific sector, and with program practitioners. So the more we know about the mental health needs and requirements from our adolescents, the more we will be able, our agencies and programs and partners in countries, to develop programs that are meeting the needs of the population. So the way the data will be presented is for practitioners. It will be presented in a way that is easy to interpret, in a way that is easy to move into action through the documents that we are mentioning today. Mercy, do you want to add to this response? I saw you had a hand up.
Liliana, I just wanted to add that Kenya recently started carrying out an adolescent health survey, and mental health is a big part of that survey. There is a little bit of interest in capturing injuries, ACEs. So social determinants are of interest, but they have been engaging with us on MMAPP tool, and I think with the finalized tool, I'm sure that the Ministry of Health would be very happy to test it. So that is a conversation that I know we will be having and others will be having with you. So we've appreciated a lot of your support in country from many of you. So thank you so much. Just wanted to bring that out.
Absolutely. Thank you so much, Manasi. That's great to hear.
Thank you very much, Manasi and Liliana. And really, again, just the focus on making sure that this tool is useful to countries so that they can take that information and design programs that are appropriate and relevant to the adolescents in that they need to provide appropriate services for. So again, a huge thanks to all the panelists, presenters, and huge appreciation to all of you who've participated today in our webinar. I have the pleasure of being able to introduce our last speaker who's going to close the webinar for us today, and that is Dr. João Pedro Azevedo. He is currently the Chief Statistician and Deputy Director of the Data and Analytics team at UNICEF headquarters. He came to UNICEF just recently from the World Bank, where he was the lead economist and an education tech fellow and education statistics coordinator within the World Bank's education global practice. So thank you very much, João Pedro, and over to you to wrap us up. Thank you.
Thank you very much, Jennifer. Well, it's as the new chief statistician of UNICEF, I'm thrilled to join the launch of the new mix module on adolescent and young people's mental health at the population level. This new module sets a critical milestone as it provides youth and the youth mental health community with an effective tool to measure adolescents and young people's mental health at the population level. And it builds on the mixed survey platform and the deep dialogue that UNICEF, global and country teams have with National Office of Statistics and line ministries. The result of this partnership at the country level are numbers that are truly country-owned, and through that have a far greater propensity to inform national programs and policies at scale. So this is a critical element of how I think UNICEF sees this as much more than a research exercise, right? We are now turning this data into official statistics at the country level, and through that, we can really mobilize much larger segments of society towards the importance of policy designs for this critical issue. Moreover, as we have been discussing, and many of the speakers have highlighted this, this module is free and it can be contextualized and for use in each settings, right? This means that researchers and country teams can now use this tool to collect data across different regions and countries, enabling a far greater cross-country comparison. And the cross-country comparability is extremely valuable, not only because of international benchmarks, but really to help give countries far greater interpretability about the reality that they face in their specific realities, in their specific context, and how they can learn from each other, right? How countries can learn from each other. This module contributes not only for the mental health science and research, but also as for practices and policies, right? And the equity-centric approach of the MAPP tool is particularly valuable in revealing disparities in access to mental health resources and treatment based on various determinants of health, such as gender, socioeconomic status, and access to education. This can inform the development of research studies and evidence-based interventions that can address multiple intersecting factors contributing to mental health, rather than just focusing on individual isolated solutions. Again, part of the use of the mixed platform, which has a range of topics that are already collected, right? The focus on the mixed tool on improving the reliability and validity of the global burden estimates of depression and anxiety among adolescents is particularly valuable. Depression and anxiety are among the most prevalent mental health issues facing young people, and having accurate data on these conditions is critical for developing of effective interventions and policies. By generating contextually relevant and comparable data across settings, the module revolutionizes how various stakeholders, including researchers and policymakers, can identify these resources, where resources are needed most, and translate data into evidence-driven action. This new mix module on mental health is unique in how it was developed, with active engagement from young people as well as academics, resulting in a module that has data that is meaningful to their personal experiences, but also the rigor that the partnership with academics has brought. This increases the usefulness of the data collected. It promotes the empowerment of the youth and as they participate on the creation of the tool. And it introduces a new dynamic on how youth can be a better advocate for their mental health moving forward. As we come to the end of this webinar, I would like to encourage us all to engage with this new module and to share it, promote it, and most importantly, use it as widely as possible within your youth mental health community. By doing so, we can rally towards the collective improvement on data and ultimately on the lives of adolescents and young people in and beyond our communities. By understanding their mental health needs better, we can address them better and armor with evidence-based policies and programs. Thank you so much for joining us today, and let us harness the transformative power of data to achieve results on adolescent and youth people worldwide. Thank you.
Thank you so much, João Pedro. I don't think anything else is needed to be added to those wonderful closing remarks. So with that, I again would like to thank everyone for participating in today's webinar. And hopefully you've received the links to the materials in the chat, and the slides will certainly be shared as well with all of you. Thank you all, and I wish you the best with the rest of your day. Thanks again. Bye, everybody.
Thank you. Bye, everyone.
Thank you. Bye-bye.